I am a cardiologist. I have spent over 20 years treating men whose hearts were failing. And for most of that career, I never once asked a patient about his erections. That was a urologist's domain. It took me years of reading the same data from different angles before I understood something that changed how I practice medicine. The inability to get or maintain an erection in a man over 60 is not a sexual problem waiting to become a heart problem. In many cases, it already is a heart problem. The same process that will eventually block a coronary artery and cause a heart attack is already blocking the arteries that supply the penis. And it started there first, years before any chest pain, years before any stress test flags anything abnormal. That is not a metaphor. That is not a loose analogy between two separate conditions. That is the same disease in the same vessels, following the same inflammatory cascade, just showing up first in the smallest arteries in your body, the ones medicine has been trained to ignore. If you are over 60 and you have noticed that your erections have weakened, disappeared, or become unreliable, what I am about to explain today is not just about your sexual health. It is about whether a cardiovascular event is already developing silently inside your body, while every standard test continues to come back normal. Before I go further, I want to say something directly to you. I know that most men who watch videos like this have already been to a doctor. Many of you were told your testosterone is fine. Some of you were given a pill and sent home. A few of you were told this is just what happens with age.
And almost none of you were told the one thing that could actually save your life, that what is happening in your erections is a window into what is happening in your coronary arteries right now, not 5 years from now. Stay until the end of this video. I'm going to explain the mechanism, the timeline, and what you can do about it, with a level of detail that most 15-minute consultations simply do not allow. The reason your erection is the first signal, before chest pain, before shortness of breath, before the stress test turns positive, comes down to a simple principle of physics applied to blood vessels. The arteries that supply the penis are between 1 and 2 millimeters in diameter. The coronary arteries that supply the heart are 3 to 4 millimeters. The carotid arteries that supply the brain are 5 to 7 millimeters. When a process is narrowing all of your arteries simultaneously, and atherosclerosis does exactly that, it will produce symptoms in the smallest arteries first. Not because the disease is worse there, but because the same amount of narrowing takes a smaller artery below the functional threshold faster. A study published in the European Heart Journal followed over 12,000 men and found that erectile dysfunction preceded a major cardiovascular event by an average of 3 to 5 years. That is not a correlation observed after the fact. That is a predictive window. The body was sending a signal for years, through the erectile tissue, and in most cases, no one was listening. The process itself is driven by something called endothelial dysfunction.
The endothelium is the inner lining of every artery in your body, a single layer of cells that controls whether the artery relaxes or constricts, whether immune cells penetrate the vessel wall, whether blood flows smoothly or begins to clot. When healthy, it produces nitric oxide, a vasodilator that keeps arteries open, flexible, and resistant to plaque. When damaged by chronic inflammation, elevated blood sugar, oxidized cholesterol, years of high blood pressure, nitric oxide production drops. And when nitric oxide drops, two things happen simultaneously. The arteries stiffen, narrow, and accumulate plaque. And the penile arteries, the smallest and most sensitive, lose their ability to dilate enough to produce an erection. This is not a coincidence. This is the same molecular failure expressed in two different organs. The man who cannot get an erection and the man who is developing coronary plaque are, in many cases, the same man, at different stages of the same timeline. The only difference is which symptom he notices first, and almost universally, the erection fails before the heart does. What makes this particularly dangerous is that conventional cardiovascular screening often misses this window entirely. A standard stress test becomes positive when a coronary artery is approximately 70% occluded. Below that, the test looks normal. But the penile arteries, being 1/3 the diameter, may already be functionally compromised at 30 or 40% occlusion, a level no cardiac screening would detect. A study from the Mayo Clinic found that men with erectile dysfunction and no known cardiovascular disease had the same long term risk of heart attack and cardiac death as men who already carried a diagnosis of coronary artery disease. The erection was the test the cardiologist never ordered. The most common mistake I see, and I include my own earlier career in this, is treating these as two separate problems. The man goes to the urologist for the erection. He goes to the cardiologist for the heart. Neither physician connects the two because the medical system is organized by organ, not by mechanism. And the mechanism, chronic endothelial inflammation driven by metabolic and lifestyle factors, is one mechanism in one body, affecting every artery simultaneously. Before going into the specific steps you can take to address this, I need to share something from my own clinical evolution, because leaving it out would mean giving you only part of the picture. For most of my career, I focused exclusively on the cardiac side: statins, antihypertensives, lifestyle modification, exercise prescriptions. I believed, and I still believe, that these interventions are foundational. But I began to notice a pattern in a specific subset of patients: men who were doing everything right. Medication adherence was excellent, exercise was consistent, diet had improved, their lipid panels looked better. Their blood pressure was controlled, and yet their erectile function remained impaired, not catastrophically, but persistently. That gap forced me to look at something I had resisted for years. I had always viewed nutritional supplementation as an unregulated space with more marketing than science. But the gap in my patients was real, and the pharmaceutical tools I had were not closing it. So I began reviewing the literature on specific natural compounds with documented vascular and hormonal mechanisms. What I found were two ingredients that addressed the precise pathways I was watching fail in these patients. The first was Andean maca, not as a libido enhancer, which is how it is marketed to the general public, but as a regulator of the central hormonal axis. Maca acts on the hypothalamic pituitary signaling pathway, the system in the brain that tells the endocrine organs how much hormone to produce. In men under chronic cardiovascular stress, that signaling becomes blunted. Cortisol, the stress hormone that rises with chronic inflammation, poor sleep, and cardiovascular strain, directly suppresses the hormonal signals that maintain vascular elasticity and erectile function. Maca does not add testosterone from outside. It recalibrates the central signal so the body resumes its own production at a level appropriate for that man's physiology. That distinction matters enormously. The second was fenugreek, specifically for its role as an aromatase inhibitor. Aromatase is the enzyme that converts testosterone into estrogen. In men over 50, and especially in men with excess visceral fat or chronic systemic inflammation, aromatase activity increases. The testosterone that the body produces gets converted into estrogen at an accelerated rate. The result is a hormonal environment that actively works against vascular repair, against endothelial function, and against erectile capacity. Fenugreek inhibits that conversion, keeping a higher proportion of testosterone bioavailable for the functions that maintain both cardiovascular and erectile health. When I introduced this combination into the protocol for the subgroup I mentioned, men between 58 and 66 with persistent erectile impairment despite optimized cardiac management, the pattern I observed was consistent enough to keep it in the protocol. Not in every patient, not with dramatic individual claims, but within 5 to 7 weeks, in the men who combined this with their existing regimen, the gap that habits and medication alone were not closing began to narrow. The improvements were measurable in self-reported erectile quality, and in several cases, corroborated by follow-up vascular assessments. I want to be precise about what this is and what it is not. This is not medication. It is nutritional support with specific documented mechanisms that address the hormonal and inflammatory pathways contributing to both erectile dysfunction and cardiovascular risk. Before I began recommending it, I verified the composition and the purity reports. I needed to know that what was in the capsule matched what was on the label, and that nothing was in the capsule that should not be. It passed that standard. The link is in the description and in the pinned comment for anyone who wants to review the composition and evaluate it in their own time. Now, the guidelines you can start applying today. The first and most impactful change you can make is to address chronic low grade inflammation through what you eat every single day. I am not talking about an anti inflammatory diet as a vague concept. I am talking about a specific shift, reducing omega 6 fatty acid intake relative to omega 3 intake. The Western diet delivers omega 6 to omega 3 ratios of 15 to 1 or even 20 to 1. The evolutionary baseline the human endothelium was designed for is closer to 2 to 1. That imbalance drives a continuous low level inflammatory signal in every artery wall, including the penile arteries. Research from Harvard School of Public Health has demonstrated that correcting this ratio reduces circulating inflammatory markers, C reactive protein, interleukin 6, tumor necrosis factor alpha, within weeks. In practical terms, this means eliminating or sharply reducing soybean oil, corn oil, sunflower oil, and all processed foods containing them. Replace them with olive oil, fatty fish at least 3 times per week, and if you are not eating fish regularly, a high quality omega 3 supplement delivering at least 2 grams of combined EPA and DHA daily. The endothelium responds to this shift. Nitric oxide production begins to recover. The smallest arteries, the ones feeding your erectile tissue, benefit first. The second change involves a form of exercise that most men over 60 are not doing, and it is not what you expect. It is not walking. Walking is better than sitting, but it does not produce the hemodynamic stimulus your arteries need to regenerate their endothelial lining. What produces that stimulus is called shear stress, the physical force of blood moving rapidly against the inner wall of the artery during intense exertion. Research from the University of Colorado demonstrated that high intensity interval training, even in modified forms appropriate for older adults, increases endothelial nitric oxide synthase expression by up to 35% over 12 weeks. That is the enzyme that produces nitric oxide directly in the artery wall. If you want to take this further and you are ready to hear this, I would encourage you to subscribe to this channel. The information I put here is the information I wish I had given my patients 20 years ago, before the gap between cardiology and urology cost them time they cannot get back. If you find value in this, pressing the like button helps this content reach men who are searching for exactly these answers and not finding them in their doctor's office. The practical format does not need to be extreme. 3 sessions per week, 20 to 30 minutes each, alternating between high effort intervals of 30 to 60 seconds and recovery periods of equal or double length. The modality can be cycling, rowing, brisk incline walking, or bodyweight circuits. The key is reaching a heart rate of 80 to 85% of your estimated maximum for those interval bursts. If you are on beta blockers, your heart rate response will be blunted, so perceived exertion becomes the guide. You should be breathing hard enough that speaking a full sentence is difficult. Consult your cardiologist before starting if you have not exercised at high intensity in the past year. The third guideline is one that most men have never heard framed this way. The single most powerful pro-erectile, pro-cardiovascular intervention that requires zero effort while it is happening is deep sleep, specifically slow wave sleep in the first half of the night. During deep, slow wave sleep, the body enters a state of maximal parasympathetic activation. Blood pressure drops to its lowest level, growth hormone secretion peaks, endothelial repair processes activate, inflammatory markers clear, and testosterone production, which occurs almost entirely during sleep, reaches its highest concentration of the 24-hour cycle. A study from the University of Chicago showed that restricting healthy young men to 5 hours of sleep for 1 week reduced their testosterone levels by 10 to 15%, equivalent to aging 10 to 15 years in hormonal terms. In men over 60 who already have declining testosterone production and reduced slow-wave sleep duration, the effect is compounded. The practical steps are specific. No screens emitting blue light within 90 minutes of sleep. Bedroom temperature between 65 and 68 degrees Fahrenheit. No alcohol within 4 hours of bed. Alcohol fragments slow wave architecture, even when total sleep duration appears adequate. If you wake to urinate more than once per night, that itself is disrupting your deep sleep cycles and may be a treatable condition worth discussing with your physician. The fourth change targets something that accelerates endothelial damage more than most men realize: the glycemic variability that comes from processed carbohydrate consumption. I am not talking about diabetes. I am talking about the blood sugar spikes that happen in metabolically normal men after meals high in refined carbohydrates: white bread, pasta, rice, sweetened beverages. Each spike triggers a burst of oxidative stress in the endothelium. The reactive oxygen species generated during that spike directly scavenge nitric oxide. They destroy it before it can act on the artery wall. Over months and years, this repeated cycle of spike and scavenge depletes the endothelial reserve. Research from the University of Texas demonstrated that a single high glycemic meal reduced flow mediated dilation, a direct measure of endothelial function, by up to 30% for 4 to 6 hours after the meal. In men over 60 eating 3 such meals daily, the endothelium essentially never recovers between insults. The solution is not a restrictive diet, it is sequencing. Consume protein and fiber before carbohydrates at every meal. This single change, eating the salad and the protein before the bread, reduces the glucose spike by up to 40% without changing what you eat, only when you eat it. Add a 10-minute walk after your largest meal, and the spike reduces further. The endothelium notices. When you look at this problem from the distance of a career spent treating hearts, what becomes unmistakable is that the men who suffer most are not those with the worst genetics or the most severe risk factors. They are the men who had the information too late. The men who treated erectile dysfunction as a sexual inconvenience for 5 years, while the atherosclerotic process that caused it was quietly advancing toward the coronary arteries. The men who passed a stress test at 62 and believed they were fine because no one explained that the test does not become positive until the disease has already progressed to a dangerous stage. The connection between erectile function and cardiovascular survival is not new in the literature. It has been established for over 15 years. But it has not reached the men who need it most. The men sitting at home, noticing that something changed, and assuming it is just age. The data on long term outcomes is unambiguous. Men who address endothelial dysfunction early through anti inflammatory nutrition, high intensity cardiovascular training, sleep optimization, and glycemic control show measurably better outcomes in both erectile function and cardiovascular event rates than men who rely solely on medication. This is not because medication does not work. It is because medication treats the downstream consequence without addressing the upstream driver. The endothelium does not care whether your cholesterol is pharmacologically lowered if the inflammatory environment that damages it remains unchanged. It continues to narrow the arteries it lines, and it narrows the smallest ones first. I want you to think about that timeline: the 3 to 5 year window between erectile failure and a potential cardiac event. That window is not a sentence, it is an opportunity, but only if you recognize it for what it is: the heart talking to you through the only channel it has before the chest pain begins. Tell me in the comments, has any doctor, cardiologist, urologist, or general practitioner ever told you directly that your erectile changes could be an early sign of an active cardiovascular process? Or is this the first time that connection has been explained to you this clearly? The endothelium has a remarkable capacity to repair itself. That is the good news. Nitric oxide production can be restored, inflammatory markers can be reduced, early plaque can stabilize, and in some cases regress. But that capacity is not indefinite. The coronary endothelium responds best to intervention when the process is still in its early inflammatory phase, before calcification sets in, before the vessel wall loses its ability to remodel. Every year of sustained endothelial damage narrows that window. The nutritional support I described, the combination addressing the hormonal inflammatory axis that connects erectile and cardiovascular health, fits within a complete protocol. It does not replace the dietary changes, the exercise, the sleep optimization, or the medical management you may already have in place. It addresses the specific gap where those interventions, in the patients I have observed, were not reaching far enough. The link is in the description and in the pinned comment. Review the composition, evaluate it calmly, and decide whether it makes sense for your situation. The patients who have done best in my practice, the ones who reversed early endothelial decline, recovered erectile function, and avoided the cardiac event their initial presentation suggested was coming, had one thing in common. They did not wait for chest pain to validate what their body had already told them. They treated the signal when it appeared. That is the difference between prevention and damage control. And after 20 years of cardiology, the distance between those two things is not subtle. It is measured in years of life.